morning. I'm David Snipoliski, one of the co-editors on the Fits on the Go blog at ACC 2016 here in Chicago. I am privileged to be here with Dr. Lonn, who will be speaking to us about her trial that she presented on here at the American College of Cardiology. Thank you so much for joining us today.
Thank you, David. Thank you. It's a privilege. Thanks.
Dr. Lonn, can you go over the background regarding your study?
So Hope-3 is, first of all, it's a primary prevention trial. It's conducted in individuals without known cardiovascular disease and at intermediate risk. So we defined risk here by age, 60 years or more in women, 55 or more in men, with at least one additional risk factor amongst a bunch of risk factors which can be easily identified clinically. People were excluded if they had cardiovascular disease or if they had any indication or contraindication to the study drugs, which included the blood pressure lowering regimen and they started.
Very interesting. Now, can you talk a bit about the results of the trial?
For the blood pressure lowering arm of the trial, using candesartan and hydrochlorothiazide, a relatively gentle regimen, we had a blood pressure lowering of 6/3 millimeters of mercury, but no reduction in events, in major vascular events, except in the subset, in the upper tertile of the systolic blood pressure distribution, meaning individuals with blood pressure above 143.5 millimeters of mercury, or what would be defined clinically as mild uncomplicated hypertension. In those participants, we did see an about 26% reduction, but people with lower blood pressure had absolutely no benefit. For the statin arm, and we use rosuvastatin 10 milligrams, we saw at 1 year at about 40 milligrams per deciliter reduction in LDL. This was slightly attenuated over the duration of the trial, so the average difference between active and placebo groups was about 35 milligrams per deciliter. We saw reduction in ApoB, in CRP, but most importantly, very consistent reductions in cardiovascular events, major cardiovascular events, about 25%. Seen on myocardial infarction, on stroke, on various composites of MACE, which we usually use in these trials. Importantly, the benefits seem to be irrespective of baseline LDL, of baseline CRP, of baseline blood pressure, of ethnicity. We had 80% of people from non-Western countries, from low and middle income countries. So it seems that the statin benefit is very consistent across subgroups of people in this category.
I think that's very interesting, and I think that's great to have in the literature, and hopefully will change clinical management in the future. What type of clinical implications do you see?
I think it should probably influence guidelines for primary prevention. And to summarize it very briefly, I think that in the majority of people at intermediate risk, we should use a statin for reducing cardiovascular disease. We should not get hung up on what the baseline LDL level is or CRP and other things, but rather administer this therapy. It seems to benefit individuals. For blood pressure, our message is that there is a benefit in mild uncomplicated hypertension, but not in people with lower blood pressure levels. And while this may appear self-evident, some previous meta-analysis suggested now there is benefit across ranges, and that's what epidemiology suggests as well. But when I go now to my office, I'll treat hypertension, mild uncomplicated hypertension. I'll use a gentle regimen. We have very few side effects, and I'll treat most intermediate risk people with a statin.
Well, that's interesting. Well, thank you so much for joining us today. I'm very glad to hear the results firsthand, and congratulations on a successful trial. To actually see a concomitant publication of the meeting, we can find the article published in the New England Journal of Medicine. Again, David Snipoliski here with Dr. Lonn at the American College of Cardiology in Chicago. To see more videos similar to this, please join us at www.youtube.com/fitsonthego.